Welcome to our Palliative Care Chalk Talk. And today we have our wonderful transitional year resident, Dr. Ashton Fitzgerald. And she's going to present to us on her interests in the intersection of palliative care and sickle cell disease. So please take it away.
Wonderful, thank you. Okay, so this will be brief, but we had on week 1 of my rotation a patient that came in her 20s and had very frequent hospitalizations for vaso-occlusive episodes related to her sickle cell disease. So I thought this would be an interesting topic to kind of paint the surface a little bit and then talk about some pain management and then just some palliative care pearls. So that is what I have done here. You can, perfect. Okay, so just a quick outline. So actually what I came to find other than, pain management is the misconceptions and the biases that providers and other healthcare staff use towards patients of sickle cell disease. So those two things will kind of be the meat of the talk. And we'll start with misconceptions and biases that are commonly used towards these patients. Okay, so after reading a little bit, it seems like it might be improving over time. However, there's still quite an overarching negative attitude of providers and other healthcare staff towards the patients with sickle cell disease. And I think it kind of starts from the second that they enter the doors. And I mean this to say that, there's biases that we have that then translate into other things and kind of precipitate the problem. And an example of this would be using derogatory language on rounds or when presenting a patient, and also using the derogatory language in the chart or when passing the patient off to like a medicine team on admission from the ED, et cetera, et cetera. And these things can lead to inadequate and inappropriate treatment for these patients. And then from a palliative standpoint can lead to just a lack of achieving a good goals of care conversation and valid goals from the patient's perspective. And then a couple other things from this point of view as well is just the general sense that we don't believe the patient's pain scale. And I know pain scales are not great evidence-based medicine scales to even be using, but it's just showing that when they come in and are describing pain, when they have this diagnosis, we are more likely to not believe their pain scale. And then assuming the patient's drug seeking or quote unquote an addict is actually a very pervasive problem with these with this patient population. And like I said before, the biased language that's used in the EMR, but also, vocally when passing patients off and things. And then another common misconception is that these patients come in every time they're in pain. And specifically in this case of the patient that we saw, she had been admitted probably 2 to 3 times a month for the last 6 months or so. And that's where these sorts of problems start to stem from, when in reality, that's not at all the case. So these are things to kind of remember and recognize that correlate with the misconceptions. Pain with sickle cell disease is the rule, not the exception. These patients manage pain every single day at home. And just to kind of elaborate on this, there was a study that had sickle cell disease patients take a daily pain diary for 6 months. And over 230 patients actually contributed the full 6 months. And what was found was that daily pain was reported by up to 30% of patients. And severe pain is up to 4% of their days. So it's kind of important to realize that just because they're coming in doesn't mean that they're not managing pain and even severe pain at home. So that's kind of one of the things that we need to keep in mind is that they're not burdening the hospital, they're not burdening us, they're coming in because they're in pain that they cannot manage at home. The other thing to remember is, like we talked about a little bit on the previous slide, is the gold standard for assessment of pain in these patients is actually their report, and in pediatric patients is family report as well as the patient's report. There is no confirmatory test to determine the quality or quantity of their pain. And this being said, we can't use the lack of anemia, the lack of hemolysis markers like LDH and haptoglobin to determine their pain. So it really is just patient report. And then just keeping in mind that other providers might not have the same understanding, education, et cetera, that we have about using the derogatory language towards these patients. So if you hear it or see it, politely correct or, make your own judgment of the situation and not necessarily take what they're saying to be a direct thing. This has been studied pretty well. Opioid misuse in patients with sickle cell disease is actually lower than a lot of other chronic conditions and is actually lower than the general population. And this just directly combats the fact that, a lot of providers and healthcare workers think that sickle cell disease patients that are on chronic opioids are quote unquote an addict. I just want to bring to everyone's attention a couple of studies that were done, and these were 20 years ago or so, and it is improving. But in 1997, there was a survey in the ED, and which consisted of the ED physicians and hematologists that were consulted to the ED. And 50% of the ED physicians and 23% of the hematologists believe that these individuals were addicted to opioids. So as you can see, that's a very pervasive, thought to have, and will definitely impact the time and effectiveness of treatment. And then the last thing I kind of want to talk about is using the word crisis. I know it's very commonly used, but actually it has quite a negative connotation and kind of implies that these patients don't manage or don't want to manage pain at home, and they only come to us when they're in a crisis. So using the word episode or acute episode is much better than using the word crisis. Perfect. So I guess my point to all this is with all the biases and things that can get passed around when patients enter the ED with these vaso-occlusive episodes is just to do your own evaluation. Don't let other biases or words used by providers undermine a good physical exam and evaluation of pain for yourself. In addition, just because a patient with sickle cell disease comes in with pain, we should really be careful of attributing their pain automatically to vaso-occlusive pain. There are much scarier diagnoses in these patients that can actually present with pain. So we need to kind of look at the whole picture and do a good evaluation for ourselves. Okay, so I just want to do a quick slide on timeline to treating these patients, and this kind of goes with the misconceptions. Once you do your evaluation and the pain you think is attributable to a vaso-occlusive episode, the standard of care is treat immediately and treat aggressively. And this is to say, whatever opioids they're on, PTA, we should never be undershooting that. In fact, a vast increase is actually what we're aiming for to get, at this point, not even ahead of the pain, but if you continue to chase the pain, that's where you get into like longer hospital admissions and worse pain and things like that. So when we treat immediately and aggressively, studies have actually shown that ED visits, admissions, and length of stay all dropped, with no compensation and other things like telemedicine, outpatient visits, contact to their hematologist, et cetera, et cetera. So I think these two things are really important to keep in mind in an acute setting. Okay, so now we're gonna put on our Dr. Seuss palliative care hat here. And we're going to talk about, pain management and acute pain episodes, which is kind of the situation that we were in when we were consulted on our patient a couple weeks ago. So I just want to do a slide or two on non-opioids in this sort of setting. Obviously, when the patient first comes in and is in absolute acute pain is not necessarily the time to run in the room and talk about, do you meditate and do you do yoga and do you do breathing exercises and all these other things. But once their pain is at least a little bit under control, day 1, day 2 of hospitalization, these are actually good times to ask the patient what else they have tried other than opioids, because a lot of them are very in tune with what they have tried, what works and what doesn't work. And these are opportunities for us to enhance their treatment once they leave the hospital. So just two things to remember. I think these are all known to us, but no cold packs ever in these patients. And then hydration status is always important to evaluate too on admission. But I think just having the discussion about, things that they tried pharmacologic and non-pharmacologically that aren't related to their current opioid regimen is really important, and could add a lot of benefit to their pain regimen at home, and then also future hospital admissions. And this is the one thing that in my reading, I actually did not know this. Combination opioids and then just using Tylenol as an adjuvant is actually not recommended for use in these acute pain episodes for sickle cell disease. And the reason is I think since they're coming in with pain and that is the one thing we're treating, you can get yourself into trouble really quickly with acetaminophen toxicity. But also in addition, these patients have a high risk for acute chest syndrome, and we don't really want to mask a fever. And so this is actually specifically in the pediatric patient population. We shouldn't be using acetaminophen at all, but in adults, it's not that it can't be used, but the patient should be monitored very, very frequently and closely for other signs of infectious processes if you're using acetaminophen. So this is sort of a busy slide, but I wanted to give myself and then teach just a little bit on dosing in acute pain. In the next couple of slides with dosing and then transfer back to PO, I'll kind of discuss sickle cell disease in acute pain episodes, but also people that come in acute pain episodes that are on chronic opioids. And in general, they follow the same rules. It might be just like numerically a little like different ways to do it, but I think the philosophy is the same. So in general for this, keeping these patients on their PTA opioids. The one thing that's kind of in the literature, if you do have legitimate concern for diversion in these patients, just start at half and then wait for, when the peak would be for that specific opioid, and then just monitor for respiratory depression and other side effects. And then you can just give them the other half and kind of move on with your management from there. And I think in general for these sickle cell disease patients that are having acute pain, if they've had a previous hospitalization, the kind of rule of thumb is to use what they used on their last hospital admission, and that seems like to be a really good starting point. And obviously it's a starting point. So I know I have that highlighted in pink, but start there, evaluate, and then you can move forward. And I think that that's better in this population versus the next bullet point, just because they know what's worked for them. And sometimes these episodes are frequently cause hospitalization. And so if you use what they last were on, it's just a really good starting point. And then you should be able to evaluate from there. But otherwise, just in general, if someone's on chronic use of opioids and they come in with pain, general rule of thumb would be if they're only on short acting, you can increase just 150% of what they normally are and leave them on the same length of interval. And if the patient is on only long acting, you can determine their total use for a day, and then you can take 10% chunks and use those as PRNs. And so I think that those, kind of remembering those numbers would give you a good baseline. And then obviously if the patient comes in unable to swallow or in more severe pain and you don't think oral would be as efficient, switching to IV is totally appropriate. Just keep in mind, for any case, if you're using a different opioid than what they are on at home, consider decreasing the dose by 25% just for the incomplete cross tolerance between the opioids. And then obviously you can reevaluate from there. For PCAs, again, you're going to use their at-home dosing, get their full daily dose, convert it to IV, and then you're actually going to divide it and get an hourly. And when you move it to the PCA, you're actually going to do half, and then you're going to use the other half for basal and half for their 10-minute lockout. So they're short boluses, if you will. And then again, with the sickle cell disease, patients coming in with acute pain episodes, a lot of them have previously been on PCA, so just make sure you look on the chart and see if that's something you can use as a starting marker. Okay, so returning to PO, so these two bullet points kind of follow the same philosophy. but basically you're looking for the use above a basal dose to be about what these patients are on at home. And that's when you kind of know you can transition them back to PO. And then as far as tapering in this situation, it seems like if you decrease by 10% at a time, and then you're decreasing the dose amount before you lengthen the time intervals, seems to be the best way to actually taper them. And then, if a patient wasn't on opioids at home, or you're taking someone that was on long acting and you're giving them now short acting at home too, the second bullet point is kind of a good starting marker. So take what they've used in the hospital in the last 24 hours, decrease it by 70%, and then you can split it up into your 4 to 6 hour PRNs. Okay, so just revisiting our hat. So other than pain meds, what else is important to evaluate in these patients? Specifically for sickle cell disease, there is a lot of psychosocial stress that can be part of this diagnosis, actually, just because it's a lifelong illness. So these are important things for us when we get on board and can have a longer conversation. What's affecting them in their life? Have there been changes that could be, precipitating these sickling events, especially if they were coming in, once or twice a year, and now they're coming in once or twice a month. What happened before that started, and what can we do to minimize the stress in those situations? And then I think from most other things, from a palliative care standpoint, it's just building rapport with the patient. It's important to recognize that these patients, especially the ones who get hospitalized very frequently, they spend a lot of time in the hospital, and the hospital is not a place that anyone wants to spend time in, especially, 2 to 3 times a month, or even twice a year at that. So, building rapport, getting to know them as a person, I think can really be helpful in this patient population. Okay, so just some takeaway points, things that I saw like recurrent in the literature, like we just discussed, these psychosocial things. And then, back to the beginning, the biases, and being aware of your own biases, and then being aware if other providers have biases. And I think this is important, to recognize before we go see the patient, especially because we have, a second, especially as a consult service, to like stop, breathe, think about the case before we go in, which is unique to the ED physicians. And then, like I said before, just using the word pain episode versus crises, just because of the negative connotation that it holds. And I want to quickly just talk about 2 other things that we should kind of erase from our vocabulary when discussing this population, is the word sickler, which I think is very obvious to everyone. We kind of refer to patients by the disease that they have and don't let the disease like identify them. But the more important one in my mind is calling them frequent flyers in the ED. And that has the same negative connotation that the word crises does. So I just wanted to bring that to our attention too. And then the last 2 points is just remembering that these patients' report of pain is really important, and it should be the one thing that drives our treatment. So to treat them immediately and aggressively. And then lastly, just, having a discussion about what have they tried, what has worked, and other things that they would, like to try or learn before leaving this hospitalization that they might be able to take with them and use at home. And then these are my wonderful children. That is Yoda on the left. She is an all-American bad A, aka a mutt. We don't know what she is, but she's full of spunk. And then my younger one's name is Tucker, and we actually got him when he was a puppy. And if you know anything about Brittany Spaniels, they are like 10 out of 10 on the wild chart. So we have a lot of fun with him. I run him and do things like that. So anyway, so I hope that was helpful. And can give you a good baseline for pain management and other things to think of from a palliative care standpoint in sickle cell disease and sickle cell disease patients.
Wonderful. Well, thank you, Ashton.
Absolutely.
And thank you, everybody, for joining us. We'll see you
Thank
next
you.
Friday.
Thanks, Ashton. That was a great presentation.
Thank you.